Okay, so chapter 2 is titled Physical Agents in Clinical Practice. And basically, we're going to talk about sort of the history of physical agents very briefly, approaches to rehabilitation, the role of physical agents in rehabilitation, what type of practitioners are using physical agents. It's not just physical therapists and physical therapist assistants. Evidence-based practice, one of my favorite categories, of course. And using physical agents effectively within different healthcare delivery systems and outcome measures. So we'll go through each of those. So the learning objectives that I have for you for this lecture are, I want you to be able to name 2 physical agents that have fallen out of favor recently, as stated in the APTA Choosing Wisely initiative, which is quoted in chapter 2. I want you to briefly be able to describe the ICF model for rehabilitation. I want you to define evidence-based practice. And I want you to describe guidelines for cost-effective usage of physical agents. So one of the reasons why physical agents aren't used as much in PT as they used to be is they are not well reimbursed. So how can we give our patients the benefit and let our employers stay in business, or allow our employers to stay in business, and have it be a cost-effective usage, basically. I want you to be able to define what is an outcome measure and then give some examples of outcome measures. So a lot of the reimbursement schemes in recent years have gone to an outcome focus, which is probably a good thing, because it used to be a time focus, like, okay, you spend this time with patient and we're going to pay you for this time. But now they're saying, we want certain outcomes, and how are you proving that you are getting these outcomes? So physical agents have been around for a really long time. And they've been used through a variety of cultures. So the ancient Greeks and Romans were sort of the first ones that had documented medical systems, and not just folk medicine. Not that there's anything wrong with folk medicine, but the Greeks and Romans were kind of the first to start documenting things. And they did use heat and water to treat musculoskeletal and respiratory problems. So you can imagine, like, breathing in steam, that sort of thing, for respiratory problems, and using hot packs for different things. I don't know how they heated up their hot packs, probably in water, I'm guessing. In 400 BC, there's documentation of the use of electrical stim using electrical torpedo fish to treat headaches and arthritis. Isn't that interesting? But physical agents go in and out. They fall in and out of favor. So it used to be in Europe, people would go to, like, take the cure at a spa or a natural hot springs, which I'm all for that. I went to Japan the last couple of years to go sit in the natural hot springs. It's not the only reason, but I'm all for taking the cure on that. There are a lot of different other physical agents that have gone in and out over the last few hundred years, which is kind of interesting. So a lot of times you get a new use for something that gets developed. Ultrasound, for example, was originally developed from sonar that they started using during World War II to detect submarines, and ultrasound imaging as well. It's sort of like after World War II, people said, oh, we have this new technology, what can we do with it? And developed some medical uses, which is kind of nice. There are certainly new uses that are found for things, but physical agents fall out of favor either because new things are found out that they don't actually do what what they thought they were going to do, or because of there's more effective interventions developed. So the example that they give in the book, which I think is a pretty good example, is infrared lamps used to be used to dry out open wounds, but they don't use them for that anymore because now it's known that wounds heal more rapidly when they aren't dried out, when they're kept moist. So a lot of times sunlight was used to treat psoriasis and tuberculosis, but now we have medical drug agents that can be used to treat those things. So a lot of times things fall out of favor because they have, there's a better way to do it. We find a better way to do it. So they talk about, which is really interesting, that heat has fallen out of favor. One of the recommendations in the APTA Choosing Wisely initiative is don't use superficial or deep heat to obtain a clinically important long-term outcome in musculoskeletal conditions, because there's limited evidence for that. So there are times when you might use heat, but it's not going to be a major part of your treatment, which is kind of neat. So we're always looking to decrease costs. We might be educating our patient. We're going to have a little section in the thermal chapter, or the thermal module, about how to educate your patient how to use heat at home. But it's not a treatment that we're doing in the clinic a lot of times, and we're not charging for it for sure. So when you look at the APTA statement, it's not saying that you can't use heat to facilitate an active treatment program. That's what we're going to focus on with our thermal agents. Like I was saying with my lady with the broken ankle, initially the active warm-up caused her a lot of pain, and so we needed to do something more passive. But that is something to remember, is physical agents are passive, and we are wanting to get our patients moving. So we're going away from passive treatments and focusing on more active treatments in general. So there are lots of different approaches to rehabilitation, and this slide really just talks about the different ones they talked about in the book. From the 80s, there was a more linear model: pathology or disease leads to disability or handicaps. There is a model, the Nagy model, which focuses on what is wrong. Sort of the current ICF model, which is the International Classification of Functioning Disability and Health from the World Health Organization, focuses on abilities, focuses on what can the patient do, what is right. And it sort of has a model of function and disability as a complex dynamic between health condition and context that the patient is in. So this is the graph that is the model of that ICF. And so the level at which physical agents have direct effects is body functions and structure, but it doesn't really necessarily have an effect on the disorder or disease. It certainly doesn't affect the patient's participation or their personal factors or environmental factors, and the goal being to increase the person's activity. So we can affect it on a small level in just one box with the physical agents, one contributing factor, but there are lots of other contributing factors that we have to take into account. So this is the APTA 2005, without documentation, which justifies the necessity of exclusive use of physical agents and modalities. The use of agents and modalities in the absence of other skilled therapeutic or educational interventions should not be considered physical therapy. So, meaning that even though the physical agents and modalities might be part, that just doing physical modalities on someone does not make it skilled physical therapy. And often, these days in the clinic, depending on where you work, a lot of times physical modalities are being applied by what are considered non-skilled people or non-licensed professionals. So it's not considered physical therapy just because you're doing ultrasound on someone. So lots of different practitioners use physical agents. They're used by us, of course, and OTs and OTAs. Athletic trainers, physiatrists, which are doctors that specialize in physical medicine, chiropractors, acupuncturists, and patients. So anybody now, it used to be that you'd have to get a prescription for TENS, and from the doctor would send the prescription to the PT. The PT would order the TENS unit and teach the patient how to use it and dispense it. Now you can just go down to Walgreens and buy a TENS unit. So that has changed a lot. So patients are also doing heat and cold modalities. They're doing taping on themselves. It's something you can do. So there are a lot of physical agents that patients can do on their own. So is that physical therapy? No. It's self-care. It's treatment. So teaching someone how to use it, that is a physical therapy intervention. It's something that you do on ongoing, but that self-care home training part, that is part of a physical therapy program. But just using the modality, that's part of your individual self-care. So different practitioners or patients might have different goals and training in the use of physical agents. So of course, we want to base everything on evidence-based practice. So we want to use the current best evidence in making decisions about the care of individual patients. It's an application of the scientific method. We ask a question, does this work to affect these systems? We test it, and then we conclude whether it works or not. And the goal is to provide the best patient care by assessing available research and applying it to the individual patient. So we've talked about evidence-based practice before, and this is and should be the basis of physical therapy practice. Is there current evidence that supports this as being an effective treatment? So this is just a little review of what we talked about before, the levels of evidence from highest quality to lowest. Highest being the meta-analyses and systematic reviews and randomized controlled trials, and the lowest being case reports. And not being evidence, if you want to, it's not on this chart, but some guy I know, this worked for me, otherwise known as anecdotal evidence or hearsay, is not considered evidence-based practice. Or, I've tried this on patients before and it's worked. That's also not evidence-based practice. That's clinical experience, and that's one thing, but it's not evidence-based practice. So the clinical practice guidelines that are supplied by and updated by the APTA, they are systematically developed statements that attempt to interpret current research as it applies to physical therapy practice. So the APTA practice guidelines give recommendations for diagnostic and prognostic measures for preventative or therapeutic interventions. So basically our clinical practice guidelines from the APTA, that's what we base physical therapy practice on. That basically defines this is what is and is not physical therapy. So within the evolving face of healthcare, if we want to call it that, we want to be able to use our resources in the most cost-effective manner. We don't want to be charging the patient for things that aren't effective. We don't want to be wasting their time or money. Reimbursement is really tight. There's reduced reimbursement for things like physical modalities and increased requirements for documentation. So if you document a treatment for Medicare or any other reimburser, and they don't like the way you documented it, they could say, we're not going to pay you for that. There's a real focus on assessment of functional outcomes in response to interventions. So an example I'll give you of someone that I just saw yesterday in the clinic, depending on when you listen to this lecture. I measured his ankle dorsiflexion with the knee bent and with the knee straight. I did my intervention, which was manual therapy and manual stretching and Graston, basically what we did, and stretching, so therapeutic exercise. And then I measured afterwards, and I documented in my assessment section of my SOAP note that after treatment, patient's dorsiflexion increased by X amount. And the goal for him is we want to decrease an ankle dorsiflexion contracture or plantar flexion contracture, so we can get him into a better brace that helps him walk better. So that's the goal. The functional outcome is that he has improved dorsiflexion, and the goal is to get him into that brace. So I need to document what I did, why I did it, and what the outcome was. So this is from the book, of course, box 2.4, requirements for cost-effective use of physical agents. We want to assess and analyze the presenting problem. So that's what the PT did when she did the evaluation. She said, okay, his walking is affected because he doesn't have the right brace, but he can't get into the right brace because he doesn't have the ankle range of motion because of tissue restrictions. She knew that using Graston as a physical agent could be an effective component of the treatment. And he's just going to be getting some Botox injections. So now is the time to use that physical agent most effectively. We want to get the most out of those Botox injections. The skill level required to apply the different physical agents, she needed to put them on my schedule because I'm a certified Graston practitioner. We want to optimize the use of different practitioners' skill levels. So she's seeing him for his gait training, but she put him on my schedule because I have the skills that he needs right then. His home program is he is stretching, and he's stretching multiple times a day. This wouldn't be appropriate to treat in a group. We have a group program for joint replacement in our clinic, and we do treat in groups when appropriate. We want to reassess the patients regularly to determine the efficacy of the treatments provided, and with him, we're reassessing him at every visit. And then we're going to adjust the plan of care according to the findings of the measurements. So the last time I got really good dorsiflexion measurements after his treatment. He maintained some of them between sessions, and so now we know that it's time to start getting that brace fitted so he can walk properly. So that's a really good example of requirements for cost-effective use of physical agents. If we did them in the wrong order, or we had practitioners with the wrong skill level, it wouldn't have been the best and most cost-effective use for him. And that's the other thing, is he has a limited number of visits on his insurance in a year, and so we don't want to use up all his visits until he can benefit the most from them. So outcome measures are used as an attempt to assess functional outcomes in response to different interventions. So the goal of any intervention should be to obtain the best outcome for the patient. So in the case of the gentleman I was just talking about, the outcome measure was his dorsiflexion range of motion for that particular goal. There are functional outcome measurement tools that may serve many purposes, but one of them is to help in goal setting. Like you're going to say, maybe you're going to do the Berg balance test, and the person scores a 40 out of 56, which indicates a high risk of falling. You say you want to improve their Berg score to 49 out of 56 to decrease their risk of falling. You can use it as a means to provide motivation for the patient, and that is definitely a valid use for functional outcome measurement tools. A lot of times I tell people, we're timing the amount of time you can stand on one leg, not just because it's fun, but because there's research that indicates that if you can stand on one foot for at least 15 seconds, you have a reduced risk of falling. So that's motivating for them. They want to work on their single leg stance because they don't want to fall. It helps you guide your treatment. So in the case that I just talked about, we know that now's the time to start fitting the guy for his brace, now that he has better range of motion, to provide a prognosis for a specific condition. So the PT is able to say, I think we can get you into this brace and it's going to help you walk better. And to provide justification for treatment. So functional outcome measurement tools, you can say, because this person scored this score on the Borg, they need skilled physical therapy on the Berg. Sorry, Borg is something different. They need skilled physical therapy to reduce their risk of falling. So you can use all of those are reasons for using functional outcome measurement tools. So here are some examples of tools: the timed up and go test. You can look these up on the internet if you want to. the 5 times sit to stand test, Berg balance scale, the 6-minute walk test, functional reach test, the Oswestry low back pain disability questionnaire. So some functional outcome tools are things that are measured by the therapist. Some of them are patient reporting tools. So the Oswestry is an example of the patient reporting tools. There's another one that's called the Optimal Functional Activity Outcome Tool. So there are lots of different outcome tools, and most of the time in your clinic, the therapists decide as a group, as a team, to which functional outcome tools they're going to use in which situations. So it's really nice because it gives you a way to show that yes, our treatment has been effective, but it also gives you some guidelines for treatment. So sometimes you look at the goals and you go, let's see what I'm going to do today. And I go, oh, they really need to work on their single leg stance because that's going to help them increase their score on the Berg. And that's what I'm going to work on today. So outcome tools give you a lot of guidelines and guidance. And they also show that your treatment's been effective.